Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, Attorneys at Law, Healthcare People, Healthcare Law. London and Amburn, Attorneys at Law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.
Hi there. Welcome to Doc Talks. Doc Talks is the Knoxville Academy of Medicine podcast where we talk about health issues in plain language that affect all East Tennesseans. I'm Elise Denaney, former president of the Knoxville Academy of Medicine, and I'm so happy that you're here joining us today. We have a very special guest today, Dr. Burkhart, Dr. William Burkhart, who is a family physician, actually is a great drummer too. And oh my gosh, so many years, we're not even going to mention because you don't look that old, of practicing as a family physician in Knoxville. Today we're going to talk about diabetes, amazing prevalent disease, so much to learn and so much that has been discovered since I even went to medical school. So let's get started. Welcome.
Thank you. Glad to be here.
Glad to have you. What is diabetes?
Well, diabetes is a disease, frankly, in common terms, where your sugar's too high. And it's multifactorial. It can be family history. It can be obesity related. It can be the fact that you're not born with enough insulin. It can be medication caused. It can be stress caused. But I think epidemically in our community, it's mainly from obesity. We've just seen that skyrocket. It's estimated in America that 10% of our population is now diabetic. And so it's become a huge part of our practice, and the challenge is getting people to reverse that before it becomes too late, frankly.
All right. I love candy. If I'm diabetic, I can't eat candy?
Well, yes and no. you need to shy away from it. The issue, with all these diets that are out now, with the keto diet, the Mediterranean diet, the low-fat diet, it all comes down to caloric consumption, and you have to put out more than you're taking in any kind of form. So some of that causes insulin to be secreted. Everything causes insulin to be secreted eventually because everything goes to sugar, whether you eat protein, fat, or carbohydrate, which is sugar, vegetables, fruits, candies, that kind of thing. It's going to go to sugar. And eventually it needs to go somewhere. It either needs to be exercised away or it's going to deposit as fat. And then that's where you get into insulin resistance. So it doesn't matter what you eat, the insulin can't seem to work, and thereby the weight goes up and then the sugar gets worse, and it's just a cycle that's hard to break, frankly.
It's
doable though, but
cycle.
It is, and I've told people I hope this never happens to me or to them, but I'd rather have cancer, because cancer is a specific organ. You can target it. Diabetes hits every organ you've got, 24 hours a day, every minute alive. It's out there, and so it's everywhere because of our circulation, and that's why it's so damaging to the body.
You said something really interesting, saying everything goes to sugar. So it's not even eating too many carbohydrates or cake or candy. It can just be overeating.
Yeah, it can be overeating. Our culture, I don't think we saw any of this probably until maybe the 90s, when, food buffet and get all you can for X amount of dollars. And it was very popular to go out to these big places that had the buffets. And people are human, and I'm going to get as much as I can for the amount that I'm paying. And so they just kept going back and going back and going back. And then that just begins to put the weight on. And so everything, no matter what you eat, it's a calorie. If you think of calories in terms of sugars or carbohydrates and fats and protein, for an amount of serving on a plate, there's twice the amount of calories for a carbohydrate as opposed to a fat or a protein. The problem is people don't half that carbohydrate. They tend to load up more on that because it tastes great, and that's what they want, So before you know it, you've doubled your caloric consumption, thinking, man, these potatoes are good, these green beans are good, or this I want another piece of pie, and you've just overdone it, tremendously, and it's just hard to catch up from that.
So why does my body not like a high sugar?
Well, as I tell a lot of my patients and my nurses, you and I are born with what I call a box of insulin. We've got a finite amount, and it is you cannot make any more. So once you are born, it's there. Now, I'm sure it matures through the years and, becomes more active and more aggressive as you eat, but it's there. That's a finite amount. So every time you eat anything that's converted to sugar, or sugar in particular, insulin is released. It allows it to go down, it allows it to be digested and assimilated into the body wherever it needs to be as a form of energy, as the form of energy basically. And then it sort of goes away. And the problem is that if you can't catch up with that, if you're not burning those calories off, then it all goes to fat, and then we have insulin resistance. And to this day, we don't understand why that's there. We don't, and I had a discussion with an endocrinologist just 2 weeks ago, is why does fat cause insulin resistance? And he said, don't know. And nobody really knows. There was an antibiotic theory, not antibiotic, but resistance theory with bacteria, all this kind of thing. But nobody really knows why we are insulin resistant, except that we are at a certain amount of weight, and everybody's trigger point's a little bit different.
That's bad, isn't it?
That's
because
bad.
One way we treat diabetes is with giving people insulin.
Yeah.
And so if it doesn't respond to it, that's bad.
And what we found out that insulin causes vascular disease in terms of peripheral artery disease. Basically, when we were growing up and in medicine, we heard of hardening of the arteries, and we heard of stiffening and those kind of things. And of course, some of that's age-related. And I tell my patients, it's like if you left a rubber hose out all winter and you tried to bend it. That's what's going on with your arteries as you get older, and that really gets their attention because they've lost their flexibility. So that's an age-related process, and that's all collagen related and all of these connective tissue stuff related that everybody goes through. But when you throw in insulin in there, it is so pro-atherogenic or so pro-clot that it causes significant damage to those vessels, and then they thereby lose circulation to the vital organs, and then that's when these little organ systems begin to collapse over time. So insulin, you got to have it, but we're now finding out with that insulin resistance that it begins to build up, and does all these damaging things for no good to the body, frankly. And so that the danger of that is if you're on insulin and you're given more and you're given more and you're given more, you're really self-defeating the problem at some point. So you need insulin, but you don't want to be on 150 units if you don't have to be.
So yeah, because then you've got other issues. You said organ failure. So things that fail would include eyesight, kidney, which means that's bad.
That's bad. I mean, you're born with two of them, and one of them's working most of the time, and one of them's sort of sitting there in reserve. The problem is no one knows which one is being affected. And so when we measure that, we don't know. We don't know which, if it's the right or the left that's doing it. And frankly, it's probably both, because one has been called into action somewhat silently to help up with the second one, or the first one, which is really not able to keep up. And so the only way we can measure that is by blood work or by urinalysis, looking for certain things there to give us a hint as to what's going on. And what surprises people is when they come in and we're just doing a physical, and how you doing? I'm doing great. Do you have any swelling? No, I feel great. How's your urine output? Oh, it's just great. And they think that's the measure of kidney function, but it's not. It's what's in there. And so we're able to tell them, look, you've already got stage 1, stage 2 renal failure. And that word just slaps them across the face, because how can it be in failure? I can urinate just fine, yeah. But I'm sorry, ma'am, it's already starting. And unless we reverse that, or at least stabilize that such that it doesn't progress, which we can do if they'll just pay attention, but you don't know where you are in the continuum until you keep monitoring that for a while. And so that's the real surprise to people, that they, in essence, did this 20 years ago, but who knew? None of us knew. We were out there doing the same thing too, trying to eat, trying to do this, trying to do that, a little too much of this, a little too much of that, I'll get away with it, I'll be fine, and then 20 years later it comes back to haunt us. So that's the problem.
It leads to so many questions in my mind. We had Dr. Tennyson on, we were talking about stress. I know stress makes some people eat their feelings.
Oh yes.
I know I do.
Yeah. I mean, there's nothing better than a chocolate sundae when you're feeling bad.
It does help.
Guilty. Yeah.
But it's the other thing that I was backtracking to was it's so important, because not to put fear as a motivator, but when you have diseases which are silent, you don't really recognize they're going on. My friend the other day had a creatinine, which is one of the tests that we use for renal function, for your kidney function, off the chart. No symptoms. in renal failure, no symptoms. Had it not been just caught, the outcome would have been worse. So that's why I think sticking with your family physician, letting them watch you grow and help monitor that whole picture of your health over, what, 30 years?
Yes, over multiple years. I've been blessed to see, our practice began in 1950 when my dad started the practice and my brother came in and then I came in, and I've seen generations and generations now, and I'm able to say, remember your grandmother had that, remember your father had that, remember your twin sister, she had that. And a lot of these folks, they just assume these are normal things of aging, but they're not. They're familial, they're genetic. And so you're able to bring that to their attention very quickly that says, this is you and them, and we need to connect that dot because that's going to happen if you don't change this, this, and this. Now, some of that's acquired. Some of it, if they're not active again, they gain the weight and this, that, and the other. But a lot of these diseases are transformational because they're genetically transmitted. It's just nobody ever thought of that until recently. The genetic code is now available and we can begin to track these things. It's absolutely fascinating, frankly.
That's amazing that you have that wonderful little arrow in your quiver. Yeah. That you understand. Not only you have this bloodline, and you understand that Mrs. X would have a predilection for diabetes because her uncle did.
Right.
And she had forgotten.
And then what they also forget is that, there used to be this, I can't go on insulin because when my grandmother was placed on insulin, they cut her leg off. Well, obviously it was so far gone that was just the last thing. And the insulins were very primitive then, and it really didn't cause that. It's just that's the association they make. But once you get them to think about it a little bit, and then they realize, aha, she had poorly controlled diabetes. I'm now a diabetic. I have hypertension. I have cholesterol. Back in that day, cholesterol was not even an entity until Mevacor came out in the 80s. Lovastatin, we never thought much about it. In fact, in my dad's day, they used to measure cholesterol as a means of thyroid function studies, because they were trying to correlate the two. So if your thyroid was inactive, cholesterol was up. And if your cholesterol was down, then your thyroid was okay. And so that was sort of a cross marker there. Nobody understood anything till the Framingham study came out in the 70s and said, we got a problem, and it's cholesterol. And now let's try to figure out what all that means. And so when you go back and track through the family and the history and the relatives and who's related to who, it gets a little bit overdone or a little bit mind-boggling, but it's absolutely a neat thing to be able to call on, frankly.
Even given a genetic hereditary risk factor for diabetes, still diet can prevent it.
Well, and most of what we see is not genetically driven. It is diet, exercise, that epidemic. When you diagnose diabetes, there's several ways. You diagnose it either by the fasting blood sugar, you diagnose it either by a random sugar greater than 200, you diagnose it by what's known as the A1C, which is an average over 3 months' time, and you diagnose it also by 2 hours after you finish or start eating. And say you eat breakfast at 9 o'clock and you check your sugar at 11 o'clock, it needs to be below 200, and if it's above 140, it's glucose intolerance or you're, pre-diabetic. We don't use the term borderline anymore because that makes people too comfortable. I'm borderline, I can get away with it. If we say you're pre-diabetic, I'm shaking them. Say, you are going to get it, It's not borderline, maybe you will, maybe you won't. It's coming. And that gets back to that box of insulin I talk about that I says it's wearing out. It's just not doing the job or it's having a hard time keeping up. The amounts may be okay. And we can do a test called a C-peptide, which tells us how much insulin you've got or if we're okay. And sometimes that's good to know, sometimes that's bad to know, but it at least gives me a framework for what medicine I need to use and how close they are to insulin and whether I need to use medicines that target insulin resistance or sort of squeeze a little bit more out, which we don't want to do because, again, you're just born with a small amount of insulin there, everybody is. Or do we give them some of the new injectables that allow them to respond when they eat? Now those have been transformational. Drugs like Victoza, Bydureon, Trulicity, those are injections that we give that do not work until you eat. And then once you eat, it sends a signal from the stomach to the pancreas that says, I've got food, and the pancreas then gives out insulin, and then it works beautifully at that point. So it's really quite neat how that works. Sort of the missing link.
I know. It's just amazing how much has come along pharmaceutically wise. But at the same time, it's amazing that all diabetes is not diabetes.
That's correct.
You know, it's your genetic predilection, what your makeup is, what your lifestyle is like, what you're able to do, what doesn't fit. It's almost like management reasoning.
Yes.
Going for everybody, every individual. That's why it's so important that.
Well, and that's what we do. We don't make everybody the same.
Right.
You know, because they're not the same. They've got other co-issues going on. They've got other medical problems. They've got all. They come to you with. We used to dread the sack full of medicine, you know, from you know, because how do I get through all of this and figure out what they need, what they don't need, and at the same time fix their problem as best we can. And so it's hard to do, but it can be done. It's just it takes a team effort. It really does to get that happening.
Oh, I love that. I love that you said it takes a team effort, but it takes also the team's not just the health team. The team incorporates you, the patient.
Right. The patient has to buy in because they're going to be frustrated, you know, every time they come in. We're not trying to beat them over the head, but we're trying to just sort of shake them into reality that, you know, and I also heard from the same endocrinologist that once you're diagnosed with diabetes, it cuts 15 years off your life. 15. Now, that's assuming most progress to a diabetic state that's not very good at all. That's not necessarily the controlled diabetic. That's the one that's just sort of out there and really doesn't buy into that. They're going to have accelerated issues with circulation, coronary disease, blood pressure, dementia, all that thing, because everything's blood driven. Everything has to go somewhere. It has to go through the blood system. It has to go through the vessels. And if you ain't got them, it's not getting there.
It's amazing. It's really amazing. So there you have it. And we've just scraped the tip of the iceberg, if you will, of diabetes. It's fascinating. And we're learning new things about it, as well as new drugs that emerge on the market all the time about diabetes. And it's so important that you incorporate all this information under the guidance of your family physician who knows you and possibly your family tree even better than you do. So thank you so much.
Oh, you're welcome.
Dr.
It's a pleasure.
Burkhart, for joining us today. If our listeners have any questions, how do they get a hold of you?
Well, I'm located on Weisgarber, which is in the center of town. My number is 633-9400. The address is 1128 East Weisgarber Road. We're very accessible off I-40 at the paper mill exit, so we're open and would be honored to take care of you.
Thank you.
You're welcome.
Thank you so much. And that's a wrap.
Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, attorneys at law, healthcare people, healthcare law. London and Amburn, attorneys at law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.